Good morning to all. I am a postgraduate student of Department of Oral Pathology, Sri Balaji Dental College and Hospital. Good morning. And my oral mucous membrane topic, part 2. So, in this part, we are going to see about non-keratinized areas. First comes the lining mucosa. It is found on the lip, cheek, vestibular fornix, and alveolar mucosa. Thick non-keratinized epithelium and a thin lamina propria can be seen here. Submucosa is loosely textured. Lining mucosa covers muscles as on the lips, cheeks, and underside of the tongue. The mucosa is fixed to the epimysium or fascia. Mucosa is highly elastic. The mucosa of the soft palate is flexible but not very much mobile. Lip and cheek. So here comes the epithelium, lamina propria, and submucosa. In epithelium, stratified form as non-keratinized epithelium is there. Lamina propria is of the labial and buccal mucosa, consists of dense connective tissue which has short irregular papillae. Submucosa connects the lamina propria to the thin fascia of the muscles and consists of strands of densely grouped collagen fibers. Loose connective tissue containing fat and small mixed glands between these strands. Strands of dense connective tissue limit the mobility of the mucous membrane. This prevents the mucous membrane of the lips and cheeks from lodging between the biting surfaces of the teeth during mastication. In lips, mixed minor salivary glands, and in cheeks, larger glands are formed between the bundles of buccinator muscle. Lateral to the corner of the mouth may contain isolated sebaceous glands called Forty spots. So here we can see a rice-like granule which is 40 spots in the buccal mucosa. So here it can be seen in the lips, that too in the upper lip. Coming to the next part, vestibular fornix and alveolar mucosa. So the mucosa of cheek and lips is attached to buccinator muscle in the cheek and orbicularis oris in the lips. Fornix, mucosa is loosely connected to the underlying structures. Movements of the lips and cheeks are permitted. Mucous membrane covering the outsurface of the alveolar process is attached loosely to the periosteum. The median and lateral labial frenula are folds of mucous membrane containing loose connective tissue. No muscle fibers are found in these folds. Gingiva and alveolar mucosa are separated by the mucogingival fold or junction. The alveolar mucosa is thin and loosely attached to the periosteum by a well-defined submucous layer of loose connective tissue, and it may contain small mixed glands. So in this picture, we can able to see the different parts of the oral cavity where the hard palate, dorsal surface of tongue, gingiva, mucosa, vestibular fornix, labial mucosa, and cheek mucosa can be seen. So inferior surface of tongue where the mucosa is thin and it is loosely attached allows free mobility of tongue. Epithelium is non-keratinized. Lamina propria, papillae or short. Submucosa contains adipose tissues. The sublingual glands lie close to the covering mucosa in the sublingual fold. So here we can see in this picture, we can able to see the inferior surface where we can see the frenulum of tongue, opening of ducts, and opening of submandibular duct 2 and submandible and sublingual fold and sublingual papilla can be seen in the inferior surface of the tongue diagram. Next, floor of the oral cavity. Here the mucosa is smooth and relatively thin. Epithelium is non-keratinized and the papillae of connective tissue are numerous but short. Here we can able to see in this picture of floor of mouth. Here frenulum of tongue and formed by mylohyoid, geniohyoid muscles, tongues and its following structures. Soft palate. Here the mucous membrane is highly vascularized and reddish in color. Papillae are few and short. Epithelium is of stratified squamous non-keratinized type and lamina propria distinct layers of elastic fibers and taste buds. Typical oral mucosa continues around the free border of the soft palate for a variable distance and is then replaced by nasal mucosa with its pseudostratified ciliated columnar epithelium. Then comes specialized mucosa. Here, dorsal lingual mucosa, where the superior surface of the tongue is rough and irregular. V-shaped line divides it into an anterior part or body and a posterior part or base. So the dorsal surface of the tongue is divided into anterior and posterior part, as we all know, by the V-shaped line. which results in anterior 2/3 and posterior 1/3 part. These two parts develop embryologically from different visceral arches. So, where anterior 2/3 is supplied by trigeminal nerve, posterior 1/3 is supplied by glossopharyngeal nerve. The body and the base of the tongue differ widely in the structure of the mucous membrane. Anterior part is papillary and posterior part is lymphatic. On the anterior part, numerous fine pointed cone-shaped papillae that gives a velvet-like appearance. These projections are the filiform papillae. Filiform papillae do not contain any taste buds. So, here we have to know that filiform papillae do not contain any taste buds. So, if you answer in some viva questions, if anybody asks you about any papillae, which doesn't contain any taste buds, means this point should be remembered by you. So, interspersed between the filiform papillae are the isolated fungiform, that is mushroom-shaped papillae. Fungiform papillae contains few taste buds. So, the V-shaped terminal sulcus between the body and the base of the tongue are 8 to 10 valid papillae or circumvallate papillae. Lateral surface of circumvallate papillae consists of numerous taste buds. Ducts of small serous glands called von Webner's glands open into the trough of the tongue. Functions. It serves to wash out the soluble elements of food and main source of salivary lipase. So, the papillae of tongue. This diagram explains the different sites where the papillae of tongue are present. So, here in the center, the V-shaped line consists of circumvallate papillae. Anterior part consists of filiform foliate in the lateral border and fungiform in the anterior part, and palatine tonsil can also be seen here. Next comes taste buds. So the shape, height and thickness are small, ovoid or barrel shaped. Then intraepithelial organs are 18 μm height and 40 micrometer thick. Outer surface is almost covered by a few flat epithelial cells which surrounds a small opening, the taste pore. So in this diagram we can able to see the taste pore which is mentioned in the previous point. Taste pore is under taste pore. What are all the surface of the taste pore? Outer surface, inner surface. Outer surface, the cells are arranged like stapes of barrel, and the inner surface cells are spindle shaped. Rich plexus of nerves are found below taste buds. Taste buds are numerous in inner wall of trough surrounding the valid papillae, folds of foliate papillae, posterior surface of epiglottis. So here we come the taste sensations. See, sweet is in the tip of the tongue. Salty is in the lateral border of the tongue. Bitterness is in the middle area of the tongue, and soreness is in the lateral areas of the tongue. So combinedly, bitter and soreness is in the palate and posterior part of the tongue. So whenever we are eating some food, we have to remember these things. So this picture is also the same thing, which is something pictorial representation of the different taste sensation of different papilla. Sensory innervation of tongue. So we read it before itself. So this is the diagrammatic part of it. So angle of V-shaped terminal groove on tongue is located as Brahman cecum, remnants of hypoglossal duct. So Brahman cecum is nothing but the remnants of hypoglossal duct that we already know. Posterior to the terminal sulcus, surface of tongue is irregularly studded with round prominences, lingual follicles, which has small pit at center called the lingual crypt, which is lined by stratified squamous epithelium. Ducts of small posterior lingual mucous glands opens into crypts. Together, the lingual follicles forms the lingual tongues. So next comes the major part, gingival sulcus and dentogingival junction, which is the third part of the oral mucous membrane in our organs. Gingival sulcus. Space between inner aspect of gingiva and tooth. That terms the gingival sulcus. It is continuous space present around the tooth. It extends from the pregingival margin to the dentogingival junction. It is responsible for the formation of groove. The groove is believed to be formed by the functional folding of the pregingival margin during mastication. So here in this picture, we can able to see the gingival sulcus, pregingival groove, pregingival margin, attached gingiva, mucogingival junction, etc. So the epithelium of which is non-keratinized type and it is thinner than epithelium of gingiva. So in gingiva we saw it is very thin and long ready peaks. Here, the epithelium is thinner than that of gingiva. So it lacks epithelial ridges and hence forms smooth interface. Continuous with the gingival epithelium. It is normal gingival sulcus depth is 2 mm. Its depth increases due to periodontal diseases, such as deepened gingival sulcus is termed periodontal pocket. 3 zones of the gingival epithelium. So it's a very important point under this topic. 3 important zones of gingival epithelium, which is nothing but the oral epithelium, clavicular or sulcular epithelium, and junctional epithelium. So these types of epithelium, gingival epithelium, can be seen in this picture. Then comes dentogingival junction. It is nothing but the junction between the gingiva and the tooth. So junctional epithelium, epithelium of the gingiva which gets to the junction. The union between these epithelium and the tooth is referred to as epithelial attachment. Junctional epithelium resembles reduced enamel epithelium in its structure in that they have basal layer and a few layers of flattened cells. Extension, it extends up to 2 mm on the surface of the tooth. So what are all the functions it's doing? It attaches to the tooth, it acts as a barrier, rapid turnover can be seen, antimicrobial defense, easy GCF flow, and highly permeable. So what is the turnover can be seen in the part 1. Already we saw in the part 1 of oral mucous membrane video. So firmness of this junction is maintained by the gingival portion of radial, that is periodontal ligament. Langerhans cells migrate to the sulcular and oral epithelium when infection or inflammation is present. The lysosomes of the junctional epithelium may have a phagocytic function. Then comes the most important thing, development of dentogingival junction and gingival sulcus. How it develops? First of all, after enamel formation is completed, enamel is covered with reduced enamel epithelium, which is attached to the tooth by the basal lamina and hemidesmosomes. Then, when tooth penetrates into the oral mucosa, the reduced enamel epithelium unites with the oral mucosa and then transformed into junctional epithelium. Then junctional epithelium proceeds in an apical direction, forming a shallow groove. The gingival sulcus between the circumference of the tooth and the gingiva encircles the newly erupted tip of the crown. Gingival sulcus then deepens as a result of separation of the reduced enamel epithelium from actively erupting tooth, and junctional epithelium attains its position at CEJ, that is cemento-enamel junction of fully erupted tooth. So here in this picture we can able to see what we saw in the previous slide. Reduced enamel epithelium covers the entire enamel extending into the cemento-enamel junction and remain attached to the primary enamel cuticle. During tooth eruption, tip of the tooth approaches oral mucosa. Reduced enamel epithelium and oral epithelium meet and fuse together. Remnants of primary enamel cuticle after tooth eruption is referred to as Nasmyth's membrane. So obviously there will be some remnants will be there. So in that it is referred to as the Nasmyth's membrane. Epithelium, it covers the tip of the crown. Degeneration occurs in the center and crown emerges through this perforation into the oral cavity. Once the tip of the crown has emerged, the reduced enamel epithelium is termed as primary attachment epithelium, which can be seen in these two pictures. Stages of shift of dentogingival junction. Here the main thing, before going into the stages, the main thing is active eruption and passive eruption. Actual movement of teeth towards the occlusal plane is active eruption. Separation of the primary attachment epithelium from enamel is the passive eruption. So in this two pictures, beside these lines can be seen as the active eruption and the passive eruption. Anatomic crown. This is nothing but the part of the tooth covered by the enamel. Clinical crown, that is nothing but the part of the tooth exposed in the oral cavity. Secondary attachment epithelium is nothing but the replacement of primary attachment epithelium by cells derived from gingival epithelium. So then comes passive eruption, where various levels of attachment can be seen here. Stage 1 stands for dentogingival junction is in the enamel, according to Gottlieb and Orban. Stage 2, dentogingival junction is located on enamel as well as on cementum also. Stage 3, dentogingival junction is located entirely on the cementum, extending coronally to the cemento-enamel junction. Stage 4, dentogingival junction is located entirely on the cementum and the root surface is exposed, resulting in gingival recession. So in the first and second stage of shift of dentogingival junction, clinical crown is smaller than the anatomic crown. Third stage, entire enamel covered part of the tooth is exposed. Next, clinical crown is equal to anatomic crown. Fourth stage, clinical crown is larger than the anatomic crown because parts of it has been exposed. Sulcus and cuticles. Secondary cuticle, ameloblast are replaced by oral epithelium. When the epithelium proliferates beyond the CEJ, the cuticle extends along the cementum. Secondary enamel cuticle and the cemental cuticle are together referred to as dental cuticle, which can be seen in this picture, where the cemental cuticle can be seen and the secondary enamel cuticle can be seen. So, together it is referred to as the dental cuticle. Epithelial attachment. Basal lamina to which the hemidesmosomes are attached. This mode of attachment is known as the epithelial attachment. Secondary attachment epithelium composed of cells derived from the oral epithelium as an epithelial attachment. It is identical with the primary attachment epithelium because of the basal lamina and hemidesmosomal attachment. Attachment between hemidesmosomes and basal lamina is referred to as the internal basal lamina. So remember, two types of basal lamina, internal basal lamina and external basal lamina. Internal basal lamina is attached between the hemidesmosomes. It's the attachment between the hemidesmosomes and the basal lamina. Whereas the external basal lamina, it differs with the internal basal lamina because they lack laminin and anchoring type of fibrils and type 4 collagen, which we saw earlier in the part 1 of oral mucous membrane. So these two pictures shows the internal basal lamina and the external basal lamina. Age changes. What will happen for the oral mucous membrane? So oral mucosa becomes smooth and dry. Why? Why it happened like that? Because epithelium becomes thin and reduction in the thickness of the epithelium lining decreases the salivary secretion, for which it became dry. So the filiform papillae is reduced as age advances. The filiform papillae is reduced and the tongue appears smooth due to reduced epithelial thickness. Nutritional deficiency may be another factor which can a contributing factor for this change. Varicose veins on the ventral aspect of the tongue are often seen, and these are termed as lingual varices, which can be seen in the second picture. And the filiform papillae is reduced, and the loss of papillae can be seen in the first picture. So the Langerhans cells, progressive loss of sensitivity to thermal, chemical and mechanical stimuli and the decline in taste perception can also be seen as age advancement occurs. Clinical considerations. So the most important thing, whatever we study, we should apply clinically. So that is the job of a dentist. So clinical consideration is very much important in this aspect. So deepening of gingival sulcus promotes periodontal pocket, which can be seen in the picture beside it. Injury to the junctional epithelium can be caused by accidental or intentional trauma, toothbrushing, flossing, or clinical probing. In restorative dentistry, level of gingival attachment is important. In younger individuals, clinical crown is smaller than anatomic crown. Then, due to gingival recession and exposure of cervical part of anatomic crown, cemental caries or abrasion may occur. So, these points can be seen in the picture beside it. So pronounced abrasion can be caused due to improper constructed clasp. So improper prosthetics can cause pronounced abrasion. Apart from that, overseal is scaling and strongly abrasive detrifices. After loss of cementum, the dentin may extremely be sensitive, so it will act to the thermal stimuli. So desensitizing or densitizing drugs should be given to accelerate sclerosis of the tubules, and then the reformation of dentin can be happened. So submucosal variation. What will be differed in submucosal category? So incision in the lining mucosa creates gaping wounds because it is loosely bound to the underlying structures, and therefore suturing becomes mandatory. So whereas incision in masticatory mucosa, that is in the hard palate or gingiva, does not create any gapping wounds because the firmness of the underlying structure. In lining mucosa, it is loosely bounded to the underlying structure, hence we need that creates a gapping wound. Whereas in masticatory mucosa, no gapping wounds can be created because of the firmness of the underlying structure. Hence, infiltration of LA is difficult in masticatory mucosa. So then comes the tongue abnormalities, disorders in the tongue. Tongue is more prone to many abnormalities. They are tongue-tied. That is, ankyloglossia can be seen in this picture. Macroglossia, excessively large tongue in this picture. Bifid tongue, right and left portions of the tongue do not merge during development. So developmental disturbances here. Fissured tongue, surface of the tongue is deeply grooved. Median rhomboid glossate reddish region in anterior tooth. So administration of drugs also plays an important role in oral mucosa. So anti-cancer drugs. So refer to oral pathology department. Anti-cancer drugs patient used to take both. So which affects the mitosis of rapidly proliferating cells, affect the oral mucosa due to its high turnover rate resulting in ulceration. Gingiva is exposed to heavy mechanical stresses during mastication. Hence, epithelial attachment to the tooth is affected. Chronic gingivitis can be caused by sharp edges of carious cavities, overhanging fillings or crowns, and accumulation of plaque. So then comes systemic diseases and its changes in oral mucosa. So not only drugs and external applications can damage the oral mucosa, other than that, systemic diseases can also damage the oral mucosa. So clinical consideration can be based on systemic diseases also. So here, metal poisoning, that is lead and discoloration of gingiva, which can be seen in these two pictures. Then comes measles. First stage of measles reveals Koplik spots in the oral mucosa can be seen here. Scarlet fever leads to strawberry tongue can be seen here. Pernicious anemia, vitamin B complex deficiency, magenta tongue and beefy red tongue can also be seen in this picture. So anemic patients can also reveal some signs in their oral mucosal layer. Then candidiasis can reveal some curdy white-like appearance patches and can be seen in the tongue. Oral cankry in lower lip, and then gumma in case of syphilis, tertiary syphilis. Mucous patches in the secondary stage of syphilis, and oral cankry in the primary stage of syphilis. Diphtheria here can be seen in the junction between the hard and the soft palate. Then chickenpox. Here, some papules-like thing can be seen in the hard palate. Then pemphigus vulgaris, pemphigoid, erythema multiforme. So these are all the systemic infections which can give rise to some changes, or clinically it can be considered the oral mucosa also. Mutation of genes encoding for CK5 and CK14 are the causes of epidermolysis bullosa or vesiculobullous lesion. Then CK4 and CK13, white spongy nevus, a congenital keratin disorder. Various genes like P53, P16, P21, etc. are involved in the regulation of epithelial cell proliferation. The altered expression of these genes occurs in oral cancer. So, end of our session. Thank you for your listening, and thank you. End of part 2 of oral mucous membrane. Thank you for your patience.